Would you be able to demonstrate then appropriate testing of quads, calf raise, along that same line to be able to overcome power?
How much time do you want to spend on physical exam?
Minutes.
Okay, a couple of minutes. Let's go pretty quickly then. Let's just run through a couple of fast ones. In low back, remember, 8% roughly L4, about 30 to 40% L5, same amount S1. So 90% together is 4-5-1. L4 is knee reflex. That's the simplest, quickest, easiest thing to do. I got my hammer over here. And as I've said so often, and I think I said this yesterday, everybody tests L4. I don't teach it because you got a hammer, you got a patient, you hit their knees, you can't avoid it. It's the doctor reflex. L5 is hip abductors, ankle dorsiflexion, and big toe extension, EHL. Anyone will do. If the patient is back dominant, as I think I told you again, I do one of those. I screen L5 with one of those three tests. My favorite, my most sensitive is the Trendlenburg. It's the one that patients don't really know. It's a very good test. Yesterday I let you off the hook. Today I'm going to get a volunteer. Be my volunteer. This is good. I'm going to pick on you first. I should have told you that before I asked you to come up. Do you know what the Trendelenburg test is?
I think so.
Do you know how it's done?
Probably not.
Good answer. All right. Describe it for me or test me with the Trendelenburg, and then we'll do it again.
What you're trying to do is assess whether the hip abductor has enough strength to keep the pelvis stable.
Very good. The hip abductors keep the pelvis level. How do you do it?
Ask them to stand on one foot. Looks like it.
What do you think?
I think it's okay.
Okay. Very good. Close, but no cigar. All right. Just slip your jacket off for me. The Trendelenburg test, you're absolutely right. First of all, it is a test of hip abduction. The idea is to watch what the pelvis does. The confusion always comes because the marker is on the offside. And that's what drives everybody nuts. Begin with this thought. I test the leg I stand on. So if I'm testing right, I want you to stand on your right. It makes sense, doesn't it? The leg you're using is the leg I test. Number two, it is a tactile test. It is far better done with what you can feel than what you can see. So the way to do it is to have the patient turn their back to you, put your hands at the top of their pelvis, and ask him to stand on his right leg. Lift your left knee like you're marching. All right, perfect. Now, what's happening is his left hip is riding up. That's a normal test. That means that the hip abductors on the right are working. Stand on your left leg, lift your right like you're marching, hip rides up. It's normal. Now, thanks very much. A couple of things. A normal Trendelenburg is a symmetrical test. That's the other simple way to remember this. I stand on my right leg, left hip goes up, stand on the left leg, right hip goes up. Symmetrical is normal. All right? Anything that is asymmetric is abnormal. All right? The easy one, the one we all learned in school, is I stand on my left and my right hip goes up, I stand on my right arm, drops. Okay, wow, positive test, big deal. You pick that up, that's kindergarten stuff. What happens if I stand on my left and my right hip goes up? Or no, what happens if I stand on my left and my right hip stays level? Doesn't go up or down. What happens if I stand on the other side and the hip stays level? Doesn't go up or down. And there are people that can do that. Their muscle balance is such, their control is such, that their hips don't do anything. They just stay level. Is that a normal test? What happens if I stand on my left leg and my right hip goes up, and I stand on my left leg, or stand on my left leg, my right hip goes up, stand on my right leg, and my left hip stays level. Doesn't go down, stays level. Normal test? No, it's abnormal because it's not symmetrical. It should have gone up. So I'm actually weak on the one side, just not as weak as when it drops. So you see, this physical exam stuff is full of really neat little gimmicks like this that you can learn. So this is a very good test for L5. The other thing I like about it, by the way, is if you're dealing with the compensation patient who's trying to exaggerate their symptoms, I always say to them, what's your bad leg? That's my right leg. Oh, my right leg's killing me. My right leg. I say, good. Let's have you lift your right leg. Okay, so he lifts the right leg, and what do I get? A big show. Oh, my God, my right leg. What leg am I testing? I'm testing his left. All right? I didn't tell him that. So there's lots of ways to make this work. Ankle dorsiflexion, I showed you big toe, pull your toe up, push it down. S1, ankle, sorry, yes?
Why is it better to do the Trendelenburg test than just to test the hip abductor anti-gravity and side lying?
I'm sorry, instead of doing it how?
Like just to have them in side lying and have them abduct their hip against
because
gravity?
it's much more sensitive if their body weight is being used against the hip abductors. If I have you lying down and I'm doing this, there are so many variables in terms of where is my hands on your leg, because the lever arm varies enormously. If I'm pushing on your thigh, if I'm pushing on your calf, on your foot. If you're lying slightly forward, it's a different set of muscles. If you roll back, it's just too complicated. It's so much simpler to just hold your hips and have you raise one leg. And then I get a consistent finding back and forth. Now, if you like it the other way, do it. These are ways to do it. As I keep saying, there's so many different ways to get at it, but I find that Trendelenburg, and the patients don't know what you're doing. It's not a test that it's commonly done, so the patients, even the ones that have been through the mill a few times, may not be wise to what you're testing. S1, ankle reflexes. The best position is kneeling. It brings out the reflex. So I have the patient kneel on the chair. You can squeeze the back of the chair. It's the same reinforcement maneuver as the Gendrasic with the Ds. Squeeze the chair, hit the ankles. Ankle plantar flexion, toe raises is S1. I don't like this one particularly because a lot of people with back pain don't like doing that because they arch their back and they hurt. If you're going to use it, the trick is to be sure that you are the balance point. Come on back up for me again. All right. Now, you're going to test my plantar flexion, okay, and you're going to tell me to steady myself over here and go up and down on my toes. So here I go. Okay, so what do you know? You don't, because you don't know what I'm doing. I'm going to now use you as a balance point. So give me your hands, and I will now go up and down on my tiptoe. Here I go. Ready? Here I go. I'm really weak, Doc. Can I have my comp now?
You bet.
Oh, I like you. Right. Was I trying?
Don't think so.
No. Why not? Because I wasn't offloading. You see, if I'm trying, if I'm genuinely trying, and I can't get up, I'm pushing down. I'm not doing anything. I'm just, we're having a great. So the point is, I can now tell whether you're giving me effort by using myself. If I'm doing this, you have no idea. So again, I need objective. Thank you. I need objective evidence of what you're doing.